Diabetes. Diabetes is a group of metabolic diseases characterized by hyperglycemia resulting from the defect of secretion or insulin action. How can we diagnose and suppose that patient suffers from diabetes? From the simple signs like polyuria, polydipsia, drowsiness, and sudden weight loss. How frequently diabetes occurs? Unfortunately, very frequently, thanks to Americanizing of our life, not only in Poland, unfortunately. 5 to 10% of diabetes are cases of the first type. 90 to 95% patients suffers from diabetes type 2. At first, we should shortly discuss immune diabetes. It's characterized by certain autoantibodies, like beta cells autoantibodies, like antibodies against insulin, against glutamic acid decarboxylase, protein tyrosine phosphatase, and known from a few years ago, zinc transporter 8. Moreover, immune diabetes is characterized by lymphocytic infiltrates in beta cells. The more frequent case with which we will be able to conduct during our pharmaceutical cognitive work is type 2 diabetes. Unfortunately, some scientists examined that the new species are evolved. First, it could be called Homo diabetes, and another Homo McDonald's. Diabetes type 2. It results from insulin resistance and or relative or less absolute insulin deficiency. Complications from untreated hyperglycemia are often the first symptoms of the mentioned disease. Discussing about diabetes type 2, we should describe two possible mechanisms. The first mechanism is theory of economical genotype. It says that during evolutionary development of a man running with such sophisticated and complicated device like a bow and spur, running after the animals, was always or almost always starving, and animals were not willing to be killed and eaten after that. Therefore, for hundreds of thousands of years, we were starving. So, our metabolic system had to develop cost-effective metabolic system. And that's why, while now we are all the time sitting and eating, unfortunately, diabetes and obesity must develop. This is one mechanism. Another mechanism is the theory of economical phenotype. It says that diabetes, metabolic syndrome, and obesity could develop thanks to who? How do you think? To our moms, unfortunately. In case of impaired gestational nutrition. Why? Because economical metabolic syndrome may not be hereditary, but it could be acquired during fetal development. Low birth weight of children favors the development of civilization diseases in adulthood. When we would like to compare the type 2 and type 1 diabetes, we have to state the differences in case of pathogenesis. In case of type 1, this is autoimmune destruction of beta cells. In case of type 2, exists combined insulin secretion and insulin resistance. Age of the onset, in case of type 1st, this is childhood and youth. In case of type 2, over 30 years it exists. In case of the first type, this type is insulin sensitive, type 2nd is insulin resistant. From a few years ago, we also know that autoimmune diabetes can be expressed even after 35 years old, even in 7 or 6 decade of life. Therefore, if the autoimmune diabetes did not develop in our youth, we cannot be sure if it develop in future, in former decades of our life. Another type is neonatal diabetes. It's defined as diabetes before 9th month of age. We should examine gene mutations. If we state that mutation conducts genes ABCC8 and KCN G11, in case of neonatal diabetes, sulfonylurea can be implemented. In case of defect of glycokinase and defect of insulin, of course, insulin must be administered. Maturity onset diabetes of the young, so-called MODY or MODY. It is inherited autosomal dominant adult kind of diabetes. MODY is associated with a mutation of single genes expressed in pancreatic beta cells like ADNF1 alpha, glycokinase, rarely HNF first beta. Resuming, MODY occurs in 2nd or 3rd decade of life. There's no obesity and there's no insulin resistance. Diabetes in pregnancy. Diabetes in pregnancy should be divided into pregestational and into hyperglycemia recognized at the first time during pregnancy. In case of gestational diabetes mellitus, in 30 to 45% of diagnosed women with gestational diabetes, type 2 develops over the next 15 years. What should we do after childbirth? After childbirth, it is recommended to conduct oral glucose tolerance test 6 up to 12 weeks postpartum and fasting glucose every 2-3 years. However, certain commonly known television doctor said that everybody lies. How do you think? Is it true? It's of course a rhetoric question. Please don't answer. If you are not certain that data implemented by a patient are accurate or real, we may recommend retrospective indicators like glycohemoglobin, like fructosamine or 1,5-anhydroglucityl. In case of glycated hemoglobin or glycohemoglobin, this molecule is a occurs as a result of non-enzymatic attachment of glucose to the glucose molecule to 3 amino groups of hemoglobin. It reflects the blood glucose in the past 120 days former. Therefore, if patient, in case of the next visit and seeing the diabetologist, is afraid of that he didn't achieve therapeutic goal, that he didn't implemented a diet before he implemented, he can start starving. If he starves from 3 to 2 days before estimation of fasting glucose, the results could be quite normal. If the doctor has real suspicions, he can order to implement examination of glycohemoglobin. If you want to check if the newly implemented drugs are effective, we can implement fructosamine. Why? Because it shows the level of glucose for last 2 weeks. Anhydro 1,5-anhydroglucitol indicates the level of glucose since last 2 days to last 2 weeks. We can also estimate peptide C. Why? We can estimate peptide C, which is equally secreted into the blood of portal vein in case of monitoring or of transplanted pancreas or islet cells. In case of suspicion of simulated hypoglycemia, or to differentiate type 1st and type 2nd diabetes. And the criteria in which patient should be focused. Venous blood plasma glucose, fasting glucose, standard of course 99 milligram percent, target between 70 and 110, but this is standards. But when you talk to diabetologists working 10, 30 years, they will tell you that 70 milligrams percent for diabetic patients is too low. The lowest level of glucose in diabetic patients should be the 80 milligram percent. 70 is too low. How could we routinely estimate glycemic metabolism? Using fasting glucose, using oral glucose tolerance test, or by determination the causal glycemia. What information comes to us from the estimation of fasting glucose? How do you think? What information? Of course, numbers. Yes or not? Yes, but the most important thing is the biochemical summary of this examination. Fasting glucose tells us how basic insulin controls glycogenolysis and glyconeogenesis, the processes which are responsible for elevating blood glucose. Oral glucose tolerance test. Another test, routine test. Why do we implement this test? To estimate how insulin is acting, the effectiveness of insulin. And criteria of blood pressure. Criteria of blood pressure in diabetes are 140 systolic per 90 millimeters of systolic. In case of nephropathy, they are more stringent. Lipid criteria. LDL cholesterol should be lowered between the 100 milligram percent. HDL cholesterol in case of male should be higher than 40. In case of female, higher than 50. Triglycerides should be lower than 100 and 150, and total cholesterol shouldn't be higher than 175. Complications of diabetes. Complications of diabetes are microangiopathy, macroangiopathy, and nephropathy. Microangiopathy against small vessels disease, macroangiopathy major vessels, and nephropathy neuropathy, damage of the central, peripheral, and autonomic nervous system. The strongest complication of diabetes is hypoglycemia. We should state the 3 stages. At first, hunger, nausea, vomiting are developed. During the second stage, exists anxiety, exists sweating, tachycardia. Against central nervous system disorder, exist headaches, endocrine, psychotic syndrome. And pharmacotherapy. In case of the type first, we should implement insulin. Can we implement oral anti-diabetic drug in case of type first? Now we know that we can, but about this drug few seconds later. In case of diabetes type 2, it could be implemented anti-diabetic drugs and, of course, insulin. The choice of oral medicines is determined by what? By effectiveness, by additional activities, by safety of use, and tolerance, and the simple dosing regimen. Among the oral anti-hyperglycemic drugs, there are groups targeted to the control of insulin resistance, this metformin and thiazolidine and ions, normalization of insulin secretion, sulfonylurea, meglitinids, DPP-4 inhibitors, and modifying glucose absorption from the gastrointestinal tract, alpha-glycosidase inhibitors. Insulin-dependent glycemic control we achieve using SGLT2 inhibitors, so-called glucoretics and flozins. Sulfonylurea. This preparation mechanism of action you know perfectly. Therefore, I have to only state that these preparations are rapidly and completely absorbed from gastrointestinal tract. Maximum blood concentration are reached within first 3 hours. Interactions. The most important interactions are with fibrates, salicylates, allopurinol, probenecide, chloramphenicol, and acenocumarol. These medications enhances the action of sulfonylureas. In case of implementation, thiazides, furosemide, propranolol, barbiturates, and rifampicin exist reduced action of sulfonylurea derivatives. In summary, sulfonylurea derivatives are effective only when the pancreas still is able to produce insulin. Unfortunately, they can induce hypoglycemia, stimulate appetite, and lead to weight gain. what you perfectly know is that it improves lipid profile, prevents fibrinogen level, increases fibrinolytic activity, increases thermogenesis. So if you use the internet fora and blogs, when you sign the sentence, what drugs is the best in case of obesity, you for sure find that metformin is the best in internet. Moreover, what should be also remembered, that metformin should be set aside in case of planned surgery, at least week before. At 48 hours before and 48 hours after implementation contrast media containing iodine. Moreover, patient taking the metformin cannot take even a small amount of alcohol. Why? Because of the risk of lactic acidosis and hypoglycaemia. There are several studies according the metformin implementation in type 1. It is known that in case of type 1 diabetes, it decreases insulin resistance, especially of liver, but also of skeletal and adipose tissue. Moreover, metformin is probably one only known anti-aging drug. Why? Because metformin can influence on the formation of advanced glycation end products. Therefore, it can stop and slow down the development of micro and macroangiopathy. It is well tolerated in case of children and adults. If any question, please stop me and ask. Maybe later. Glitazones. When glitazones should be administered? Only in case of huge insulin resistance. This is one indication for implementation of glitazones. Unfortunately, they can stimulate congestive heart failure, they can stimulate retention of fluids in the body, and it can higher the level of LDL cholesterol. Inhibitors of alpha-glucosidase, acarbose, miglitol, voglibose. To what patient mentioned inhibitors should be administered? For patients who like to eat, who like to eat, especially for patients who like to eat high carbohydrate meals. Side effects of mentioned inhibitors are bloating, excessive gas extraction, and diarrhea. New trends. When we want to discuss new trends of diabetes pharmacotherapy, we should shortly discuss incretin effect. What does it mean? Incretin effect means that the greater insulin secretion after the oral glucose administration when compared to insulin secretion after intravenous glucose administration. One colleague was yawning. What is yawning? According to the scientists from Princeton, it's not the sign of being bored, but yawning, you know, yawning is a method to lower temperature of our brain. So, if we are yawning, we are helping ourselves to implement to our brain the knowledge. So I'm not angry with my students when they are yawning, and I tell them, yawn every time. If they need to. It is better if they sleep with me or without me. Of course, in a lecture room. Discussing new group, DPP-4 inhibitors. We have to say that they control hunger, they stimulate insulin synthesis and secretion, but only in case of situational circumstances when the insulin is needed. If exists hypoglycemia, DPP-4 inhibitors does not stimulate insulin secretion. Therefore, there is no risk of hypoglycemia implementing this group of medicines. However, unfortunately, there are serious threats. Several sources tells us that unfortunately DPP-4 inhibitors can stimulate development of acute pancreatitis. There are a few agent substances. The newest one are dutogliptin and gamigliptin. Exidine agonists. The introduction of Exidine agonists was gained by the estimation and statement that in the saliva of lizard, Gila monster, this lizard lives in Mexico, exists peptide that mimics action of GLP-1, one of the incretin. It acts similarly to, in a nutshell, to the DPP-4 inhibitors. Interactions. There are some interactions. There are two important interactions in case of DPP-4 inhibitors and Exidine agonists. Prothrombin time should be strongly controlled, especially when patient is taking coumarin. Moreover, proton pump inhibitors should be taken at least 1 hour before the implementation DPP-4 inhibitors. Pramlintid is one of the newest drugs. It is able to slow down the stomach emptying and inhibit production of glycogen in a mechanism of glucose-dependent phenomenon. Glucoretics. They are SGTL inhibitors. They inhibit reabsorption of glucose in the proximal kidney channel, which influence reducing of glycemia irrespective to insulin. They provide better control, better glycemic control in the mechanism independent on insulin. They are responsible for weight loss and lower risk of hyperglycemia. Disadvantages, unfortunately, weakness and high risk of infections, urinary infections, unfortunately. Therefore, women don't like to take these medicines, unfortunately, but they are extremely effective. New research directions. New research directions at first should be discussed bromocriptine succinate. It influence on dopamine receptor activity in hypothalamus. It improves glucose metabolism, reduces insulin resistance, reduces cholesterol level. They are not, this substance is not responsible for weight gaining, does not increase the risk of hypoglycemia. Another way of scientific activities in the field of pharmacotherapy of diabetes is sotagliflozin. We discussed flozins. They are SGTL2 inhibitors. Sotagliflozin inhibits not only SGTL2 but also the first one. But the total inhibition of SGTL1 is impossible. Why? Because it exists in gastrointestinal tract. If we inhibit totally, severe diarrhea would exist and patient would be would suffer from severe weight loss. So only partial inhibition of SGTL first. Moreover, this drug is responsible for lowering blood pressure. It also helps to increase GLP-1 secretion in intestine cells. Another newly implemented drug is oral lean. Oral lean is insulin aerosol administered into the mucous membrane of oral cavity. Another one is a biodegradable polymer of nanoparticles coated with insulin. It would be the breakthrough, in my opinion, because it would be the first drug which allows to take insulin orally. Prophylactic pharmacotherapy of diabetes, is it possible? Yes, it's possible. Some of us are doing this every day, but we don't know about it. First, we should shortly characterize vitamin D. Why? When vitamin D deficiency exists in the early period of our life, it predisposed to develop diabetes type 1 and diabetes type 2. So if we have children or if we are planning, think strongly about vitamin D. Orlistat. Orlistat is a medicine which is responsible for gastrointestinal lipase inhibition. I'm almost finished. Gastrointestinal inhibition. It also, from 2 years ago, we also know that it also stimulates incretin secretion. Statins are indirectly responsible for diabetic, especially type 2 prevention. Why? Because they are lowering pro-inflammatory cytokines, TNF alpha, interleukin 1st, 6th, and 8th. Angiotensin converting enzyme inhibitors. They act in two mechanisms, hemodynamic and non-hemodynamic. They are reducing insulin resistance and lowering glucose level. And pre and probiotics. Using pre and probiotics, it also can be named prophylaxis of prophylactic action against diabetes. Insulin for the end. Insulin was introduced in the 1921st. Not from today, we know that there is no justice in the world. It was discovered by Frederick Banting, the man on the right side, and Charles Best. Professor Banting was given the Nobel Prize, but Dr. Best wasn't given the Nobel Prize. Another person who was given, thanks to this achievement, Nobel Prize was their chief, George MacLeod. But thanks to history, we don't remember about George MacLeod. We remember about these two guys. Because Dr. Banting was a gentleman, he gave to his colleague, to his assistant, his half of a Nobel Prize. When insulin was the first implemented, it was the 1992. The first patient was Leonard Thompson. The first day of implementation of insulin was 15 December of 1992. Patient was suffering from diabetes. His weight was 8 kilograms. He was 14 years old. After 2 months of insulin implementation, his weight jumped to 16 kilograms. Thanks to the implementation of insulin, he achieved 70 years of living. how insulin works. Insulin is the strongest anabolic substance in our body. We are not able, if we take insulin, insulin using medical devices, we are not able to examine is it our or manufactured insulin. Therefore, this statement was used by who? How do you think? By sportsmen, especially athletes. When insulin should be administered? Insulin should be administered in case of latent autoimmune diabetes of the adult, diabetes type 2, and gestational diabetes mellitus. But you should know that in England and in Australia, metformin and glyburide is also administered in gestational during gestation. Why? Because pregnant women in those countries are unfortunately obese. In our circumstances, there are no reasons to implement metformin during pregnancy. When insulin should be implemented? When glycemia exists greater than 300 mg/cent, when glycohemoglobin exerts 7%. How insulin therapy should be divided into the intensive, functional, and conventional. Conventional means implementation of premixed insulins, human and analogs. In case of intensive, short-acting insulin is administered before main meals, and long-acting insulin is administered in the evening or in the morning, and for the end, some interactions. What OTC we should excrete from the implementation in patients with diabetes, especially salicylates. Why? Because in case of oral antidiabetic drugs, they can stimulate hypoglycemia. Moreover, pseudoephedrine should be excreted. Why? Because pseudoephedrine shrinks blood vessels. It stimulates the development and increasing the rate of development of nephropathy. Moreover, it increases the blood pressure. Therefore, in most cases, in most patients with diabetes type 2, these patients suffer from hypertension and coronary artery disease. Therefore, OTC drugs cannot be implemented in those patients. Moreover, in case of mimetics, alpha-adrenal mimetics, we should use extreme caution when we suggest nasal drops. Why? Because they also can higher the blood pressure.